Okay, well, welcome everyone to tonight's latest installment of the AMSSM Sports Economics webinar. I'm Edward Smith, Primary Care Sports Medicine Fellowship Faculty here at the University of Minnesota in Minneapolis, and I'll be serving as your moderator tonight for this upcoming exciting talk from Dr. Julian Perez. Before we get started and into the thick of things, just a few housekeeping items. Computer screens, if you guys want to keep those off while Dr. Perez is talking and while the webinar is going, that's great. Make sure your microphones are muted also. All questions, if you like, for the time, go ahead and put them in the chat, and then afterwards we can address those. I'll read them off to Dr. Perez, and we can answer those questions at that time. Also, as an aside, this webinar, like all of our webinars, will be available on the AMSSM Sports Economics YouTube channel. So be sure to watch this one and all the other ones that came before this as well. And very exciting because we have these quarterly. Our next webinar will be on December 4th. The topic will be the case-based process of starting a business. The speakers will be Dr. Michelle Hinney and Siraj Abdullah, and Dr. Marcia Newby Goodman will be serving as the moderator there. So as we get started, again, I'm very excited to have the pleasure of introducing you to Dr. Julian Perez, who will be discussing and focusing on sports medicine practices in federally qualified health centers. A little background about Dr. Perez. He serves right now as the clinical director of the Community Health Sports Medicine Department at CMAR Community Health Centers in Washington State, not the other Washington. His main practice is in the Seattle area. He covers boxing for the organization, Summer League Baseball, which we were actually just talking about, local dance groups. So needless to say, he's very busy, and he's soon expanding his coverage to include local rugby leagues and roller derby, so making it even more busy. Dr. Perez earned his degree from the University of Washington School of Medicine in 2004 and graduated from Providence Family Medicine residency in Seattle in 2007, which we now commonly know as Swedish Family Medicine at Cherry Hill. He practiced full spectrum family medicine, including hospital admissions and labor delivery for 7 years before returning to fellowship with Swedish Cherry Hill Sports Medicine. His fellowship was completed in 2015, and he continued full spectrum family medicine with his CAQSM until 2023. Dr. Perez recently left his hospital practice in order to form a FHC-based sports medicine fellowship to fill the need for specialty musculoskeletal services for the underserved population. So he's doing great work there, and he continues to practice family medicine as well. He's also an associate clinical faculty with the University of Washington School of Medicine, where he teaches medical students, residents at 2 different locations, as well as nurse practitioners. And Dr. Perez wants us to make sure that we all know that he's married to his wife of 17 years, and he has one awesome gymnast daughter. So without further ado, Dr. Perez, I will turn this over to you and let you run this show, my friend.
Ed, thank you. And I want to give a big round of applause to the committee that invited me to do this. That is Edward Smith, Andy Meyer, Elliot Hugh, Marcia Goodman, and last but not least, President Rebecca Myers. I had a really great talk with Rebecca over some beers at AMSSM, and she just has such a passion, such a heart for people that are struggling, people in the underserved areas. And she voiced the same thing that I hear many of you voice, many of our colleagues voice, which is that we want to do more work in the underserved areas. It's just tough to figure out how to pencil it out. So tonight's talk is a way, a place to do that work and have it pencil out. And so without further ado, I'll bring my slides up and we'll get at it. Okay. All right. Well, this is the economics webinar. I work at a community health center, and what we're going to do tonight is go through the nuts and bolts of what an FQHC is, and the people we serve, the mission we have, the funding we get, and how we have integrated sports medicine into a primary care heavy practice here. And I am looking to see, there we go. Now I know how to move these slides. Okay, so the goals of the talk. What's a federally qualified health center? What is the scope of practice, and who's our patient population? Second goal, know the basic reimbursement model of federally qualified health centers. And number three, know about a new model to integrate medical specialties under a primary care roof, which leverages a different payment model. All right, so what's an FQHC? We're funded by public tax dollars from the Health Resources Services Administration, otherwise known as HRSA. And that is a department under the umbrella of the U.S. Department of Health and Human Services. We're community-based and patient-directed organizations. What that means is that we are not-for-profit. We have boards of directors, and the patients make up over half the members of the board of directors, which means they run the place and they truly own and operate it. Okay, well, we operate it, but they truly own it. And most of our employees are patients as well. Federally qualified health centers deliver comprehensive, culturally competent, high-quality primary care health services. And this primary care health services is open to interpretation, which is why we're starting to expand into other places. Often integrate pharmacy, mental health, substance use disorder, oral health services, i.e. dental, and now medical specialty. The key is that we integrate. We try to meet the patients where they're at. We try to put as many services under one roof as possible so that our patients can get the care they need, and they are directing that by the board of directors. Target populations, areas where economic, geographic, or cultural barriers limit access to affordable healthcare services. So you'll see federally qualified health centers in urban and rural areas, oftentimes specializing in specific populations. Mine was founded to take care of Mexican migrant workers back in the 70s. Right now, we take anybody that comes to our doors. So who are patients? These are the nation's most vulnerable individuals and families, including patients who experience homelessness, agricultural workers, residents of public housing, and our nation's veterans. Quite a good population to take care of. Very, very thankful. Very few lawsuits. Very fun to work with. All right, so why did we start this? Well, I learned that musculoskeletal was about 10% of what walked through the door. When we take care of a blue-collar population, a lot of folks that are here doing labor, it's more like 20%. And we needed to raise the bar. We needed to do better for our patients. So 7 years into primary care practice, I realized I needed to go back and get some more training. And the sports medicine fellowship was the way for me to do that. That said, we also understand we don't need to send everybody to surgeons. And we were burning a lot of bridges, sending patients with back pain, patients with tendonitis, patients with, very bread and butter problems to surgeons. And that was not going well for us as an organization. One thing that my patients care a lot about is being able to work, being able to show up and play. And when they have disability, it really, really messes with their lives. So you can see in this huge graph of all the different problems that come to us in healthcare in the United States, a big chunk of that is disability. And we're uniquely positioned as sports med docs to take our exercise physiology knowledge as well and apply that with evidence-based exercise prescriptions to treat and prevent, these problems. Very common things we see all the time. And when it comes to falls, as you guys know, if somebody falls and breaks a hip, you're talking potentially millions of dollars that are going to be spent on that person until, before the end of their life. So this is a really important place for us in primary care to make a big dent in disability. So let's talk about high level, bird's eye view, macroeconomics of healthcare. The federal government gives out billions of dollars to all the states, and we use that for Medicaid. Medicaid as a program was started to fund the homeless, the indigent, folks with blindness, folks missing limbs. These are the days when people were working in very unsafe conditions and they were losing eyes and limbs all the time. Now Medicaid, under the America Affordable Care Act, has been expanded to take care of people that meet a certain percentage of the federal poverty level. Right now it's at 400%. 400% with the ACA. And initially, where the poverty level was 100%, for example, if the ACA bumped it up to 130. And so this really enabled us as primary care physicians, federally qualified health center workers, to get our patients insured. And so where we were providing so much uncompensated care before, now our patients were qualifying for Medicaid, and we're able to get paying customers. And this matters, and I'll explain how in a bit. But each state gets to allocate these dollars. Very important concept. Take Washington State in blue. Overall, of those Medicaid dollars, 0.76 of those is used for healthcare. There's a lot of things that Medicaid can go into beyond the scope of this talk. 0.66% of that is spent in primary care. 1.07, essentially, think about these on pennies on the dollar, 66 cents per dollar is on primary care for reimbursement. OB care, that's moms and babies, $1.07. Okay, $1.07. So this is actually a big one in Washington State. Anybody will take Medicare to take care of pregnant women and their little babies. However, that has to come at the expense of somebody, and that ends up being in the other category, which is specialty care. We can't get beg, borrow, and steal any orthopedic surgeons to see our patients. Very, very tough, which is why we started this program to get more non-surgical orthopedic care and sports medicine in our clinics. So let's fast forward now to 2019. Everybody gets to change these. Take a look again. These are the allocations here. See how they change, right? Now, at the time of the Affordable Care Act, only three people on this list had expanded their Medicaid. Right now, everybody on the list has expanded because they've seen the advantage of making sure you can get federal dollars to take care of people who have no other way to get health care. They're going to pay. You're going to pay for them one way or another. It's better to pay for them up front with preventive care and coordinated management than it is to have them end up in the ER over and over and over again with things that could have been dealt with months or years ago. And so in Washington State, we've changed our allocations just a bit. But as you can see, those dollars are getting allocated the wrong direction everywhere. And so it's even more important that our service exists here on the sports medicine clinic. So the nice thing about working in a federally qualified health center is that, you have brick and mortar and you have budgets. And so if I wanted to open up a clinic, hang a shingle as a private doc, I got to find a loan, right? That's, not the hardest thing to do, but then you have to make sure you take whatever interest rate they give you, and you got a lot of pressure to make money and pay the bills. If I work for a federally qualified health center, I show up, I get salary, and they pay for everything. They paid my ultrasound machine, they gave me a state-of-the-art X-ray, and I got to design this myself with our own architect. And now I have a place where I integrate doctors, PT, OT, imaging, cardiology, optometry, all under one roof, all for the patients. Best care anywhere. So here's our mission: to provide access to orthopedic and sports medicine care for our patients in a community health model. Our vision is thriving families through active lives with no barriers to work, play, or healthcare. No barriers. And our values include service, justice, dignity, integrity, advocacy, using evidence-based medicine and methods to take care of people. All right, so let's talk about our goals internally. We want to improve access for our primary care docs, our primary care nurse practitioners and PAs to musculoskeletal care, and we want to provide great quality, okay? We need shorter wait times. Our patients were waiting forever to see somebody, and they went from an acute injury to a chronic injury into a chronic disability, losing their homes, losing their jobs, losing their families. It was terrible. We had to get a handle on this. We want to decrease disability and get patients back to work and sport much sooner. And with the models that we're going to talk about tonight, we save everybody money. One thing that we've embraced in this state is something called value-based care, where we have contracts with different Medicaid partners who manage those dollars we talked about. Each one of them we sign a contract with for a certain number of patients, a certain number of lives that we're responsible for. We have to then estimate what it's going to cost to take care of them. And in doing so, the contract says, well, if you come out ahead, we get to split that savings, okay? And so that incentivizes us to use very creative ways to save the money. For example, if I have a patient who needs orthopedic care, previously I would send them out to somebody. They may charge 2 or 3 times what we would charge here to take care of the same problem. And they may not do it with, as good cultural and language capacity as we have internally for our Spanish-speaking patients. And so now that we're able to take care of our own patients, we send a lot fewer patients out. That is tons of money we save, and we get to pocket half of that at the end of the year. Okay? We want to make sure we raise up. We want to elevate our own providers, and so we want to teach them MSK skills. I do a lot of co-management. I do a lot of curbsides for them. We got state-of-the-art brick and mortar facilities, more minimally invasive ultrasound guided treatments like your tendon debridement, carpal tunnel releases. We want to grow our in-house diagnostic musculoskeletal ultrasound services. So I look for folks and I hire them based on those skills. We integrate PT and OT under our primary care roof. I literally can see my PTs and OTs working in the gym in front of me. I talk with them, we collaborate, we coordinate care. It's really fun. We want to publish our model in medical literature and in the physical therapy literature so that other people can try this too. We're doing more sideline event coverage in preparation for that fellowship that Edward talked about. And we want to ultimately have a fellowship so we can address our own shortage, service shortage in underserved areas. So let's talk about some internal data. When I was in fellowship, I wanted to see what the data looked like before, during, and after the fellowship and see what we could actually quantify as far as an impact. So we took 2 areas. Clark County is a county down by basically Portland, Oregon. It's on the border of Washington. Vancouver is the city that's on the opposite side of the border. We have a big clinic system there, about 5 clinics, and they generate just as many referrals to musculoskeletal services as we do here in King County, which is where Seattle is located. So kind of think about this as a Portland area and a Seattle area. All right. So the percentage of increase in musculoskeletal referrals in Clark County, which is that Portland area, was 37%. When I got out of fellowship and we were able to prevent these things from going out, we only grew by 7%. And that is money saved. That is patients that don't have to leave a place that they know about, that they know we speak their language, and that they're comfortable coming to, and they feel safe and well taken care of here. I've talked with our patients. When they have to leave the clinic, they have to drive downtown. Sometimes it's a bus or two, or they got to find a parking spot, 20 bucks an hour downtown Seattle. They're rising up in the skyscraper, 50 stories in the air. They've never been in a skyscraper in their life because they just came from Cambodia. And now they're having to talk with somebody in a language that, you know, maybe they do or do not provide interpretation services. So it's very, very nice to keep people on site. So more data here. Again, looking at that Clark County, Portland area, looking at the control group, you know, as it were, the intervention, 4,266 total referrals that we had there. We were able to decrease these in the blue. Those were the visits that we did on site here in the sports medicine clinic in the first year out of fellowship. And I was only seeing patients 2 days a week. This is much more impactful at this point. But this one is really important, especially to our Medicaid payers, is MRI volume. I know you guys are probably right with me, which I'd rather stick a spoon in my eye than have to call somebody again for a peer-to-peer to get prior authorization for an MRI. I can really do a lot of diagnostics here with my ultrasound. I can save that headache for me and my staff, and we were able to successfully decrease the volume of MRIs that were made out of our organization just 1 year after fellowship. So these numbers matter. They matter to my leadership. They matter to the patients. They matter to the docs, and they matter to the bottom line, which means that we can take that money, put it back into the clinic, and take care of more people. So let's talk about services under the roof. On the left, you're going to see essentially what we do. We have sports docs, PTOT. We have X-ray in-house, lab, pharmacy, other medical specialists, nutrition, and health education, which I use as basically health coach, you know, for motivational interviewing. And the nice thing about our practice is that we implement primarily sportsmen docs that are comfortable with all ages. We do ortho consults, we do those ultrasound guided procedures and minimally invasive surgeries. We're integrating therapy in the same day. We manage concussions, and we do low risk fracture just like you guys. All right, so you guys all know about these companies and this technology, which hopefully everybody's starting to get online and train in. It is wonderful stuff. It's so satisfying to release a carpal tunnel in clinic and not have to send them out with a 6-month wait for charity care at the county hospital. Okay, so let's talk about the nuts and bolts, the dollars and cents. Federally qualified health centers are community health centers with the added Joint Commission accreditation. So what's the Joint Commission? That is an organization that looks at hospitals and other entities that do large volume healthcare to make sure that we're providing quality care, safe care. Okay, quality, safe care. They come every year, they do site visits, randomly pick a clinic, randomly pick a doc, randomly pick staff. They ask us questions, they make sure that we know where policies and procedures are. They come look for blood on the wall, they come look for, you know, stains on the carpet. They want to make sure this is a quality place to get care and that it's safe and that we know what we're doing. We have been in existence going on 60 years now. We're one of the biggest community health centers in the country, and we've been Joint Commission accredited that entire time, never having lost our certification. So that's really something we're proud of, and it takes a lot of work. The rub here is that with the accreditation comes big time quality, safety, access, rules, and regulations. So it's a little bit heavy on the red tape, but we have very good management that helps to protect us from that as providers. You don't feel it too much as a doc. In exchange, we get paid as a federally qualified health center, Medicare rates for Medicaid patients. So let's say, you know, for private pay, maybe you're going to get $1, right? Medicare, you're going to get 80 cents, maybe 70 cents. Medicaid, you're getting 40 cents, right? We get Medicare rates for Medicaid patients if we have that Joint Commission accreditation as a federally qualified health center, which means that under the Affordable Care Act, we're now able to sign up so many more of our patients for Medicaid because they meet the minimum expanded, or they meet that expanded poverty rate definition, and we get paid Medicare rates for that. So it's a twofer. As soon as the ACA came out and we started to sign people up, we just started exploding, opening clinics left and right, hiring staff left and right. And it's been really, really great to have that extra impact in the state of Washington. All right, so we're not for profit. We get to deduct losses at the end of the year, right? That's pretty good. Value-based reimbursement model. So we talked about that shared savings where we have contracts with the state of Washington with those Medicaid contracts. Again, you're a little bit risky here, right? If you cannot come in under the budget that you set out for yourself, and that is not just me waving hands, like I have to take a look at my ICD-10 codes. I have to submit all this stuff. And we make sure that we define our patients, not just in their medical complexity, but also in their social determinants complexity, because that matters to the state of Washington. And we're able to roll that in somewhat to the calculation in order to make an estimate of what it's going to cost. And so there is a risk there that you may come in behind and you may lose money on this. All right, so this is a standard sliding fee scale by the federal government for all federally qualified health centers. And a patient that comes into you who says, you know what, I don't make a ton of money, but maybe I can pay what I can pay. Look, they can get a discount. And so they take their 2-week paycheck and how many people they're supporting under their house, under their roof, and we make a calculation. It's all done at the front desk. They're told immediately what their discount is, and then usually they feel a lot better about coming and getting care. We also have pharmacy that has a 340B program, which is a federal program to buy medications in bulk and also drop the price. You know, so something like an empagliflozin, which is a new diabetic medication, $400 at Walgreens, it's $45 a month here. All right. So how do we add specialty under our primary care roof? We have the federal model, you know, economies of scale. We get those Medicare rates for Medicaid patients. The key here is that there's unlimited patients. I mean, there's no end. I could open this place 24/7. They would come day and night. There's no end to the work. And so, you know, you don't have to worry about, you know, growing your business. It's going to happen all by itself. There's subsidized reimbursement, and we deduct losses at the end of the year by the process we call reconciliation. So we have the state contracts we talked about as well. And we save by not sending patients out for care. Talked about that. All right. So let's review the goals. FQHC is what? We're funded by tax dollars, owned and directed by the patients that we serve, to provide integrated primary care services for underserved communities. That's who we are. That's what we do. That's our scope of practice. Our reimbursement model is a combination. We have Medicare rates for Medicaid patients. We have a sliding scale fee for them. And now we're integrating, bullet point number 3, are these value-based contracts with Medicaid payers. So that, and we leverage that by saving on the back end, by growing services under our primary care umbrella. We have specialty services under the primary care umbrella, which we define as primary care, and the state lets us do that, so that we can save on the back end by not sending them out. And that allows us then to add sports medicine, to grow with PT and OT, to add a cardiologist, to add an optometrist. We had rheumatology, we had nephrology, we had dermatology. So a lot of fun to make basically what amounts to a polyclinic using these payment methods. Okay. So we're getting access to specialty services for our underserved patients. There's no limit to the customers. Facilities, equipment, and management is covered. We don't worry about the admin. You know, we can take leadership roles. I'm a clinical director. Every clinic has a doctor that's a medical director that handles a lot of the end of year evaluations and, you know, meets once a month with other medical directors. But by and large, you know, we have leadership that handles, you know, the nuts and bolts, the dollars and cents of this. Economies of scale, right? So we're subsidized models. And we're saving money on that back end that allows us to add sports medicine under the primary care roof. And then we incorporate the for-profit corporations under not-for-profit umbrellas when possible. So for example, that architect I told you about, he's a for-profit architect, but he's paid by us under the and contracted under the umbrella. We also have our own construction team. Anything that needs to be built or remodeled, it's our own group. It's under our umbrella. Not everybody obviously has the economies of scale to pull that off. There's FQHCs out there that are one building, brand new in our community, but as they grow and we share these ideas, people are able to implement them and slowly take on some of these ideas themselves as well. Okay, and here's the rub. You got a low overhead. It's got to be evidence-based. There's a ton of volume. So that sometimes you're here late working. All right, guys, that's what I got for you. We wanted to leave plenty of time for Q&A. Make sure that we can talk about your specific situations, ideas you have, thoughts about, you know, models that you're working on. Thank you.
Awesome. Dr. Perez, that was fantastic. Thank you for that presentation and all the extra information as well. I do want to point out, Dr. Hugh put this in the chat for everybody that may have missed that also, but the AMSSM board did approve this particular topic for those that are interested in helping. They're actually working on a research and collaboration project. So if there's something, if this topic is something that you are absolutely interested, you can join that subcommittee and learn more information and also find out ways to help. So this is great. And Dr. Perez, I'm sure you even beyond that is on that also. So thank you. We do have some questions already popping up in the chat, and we definitely have some time here. Off the top, also, Dr. Perez, thinking back, especially with one of your first slides when you were talking about the Medicare to Medicaid fee index. I'm
Yeah.
curious, was this something that you knew about when you were initially looking for employment? It was that,
No,
when you're okay.
no.
Okay. What was your path to the federally health care center or qualified centers? How did you end up in that pathway?
Right. So, I'm going to tell you a little bit of a long story because we got some time. So my mom and dad were Mexican migrant workers. They picked, potatoes, they picked cherries, they picked strawberries, they moved pipe, and they did that through Texas, California, and eventually Idaho. So I was born in Idaho, and my dad was the first to go to college. They raised us up with service as a way of life. We had a house with a basement. We could have been using the basement to sleep in, but they turned it into one great big clothing bank, so all the people from church came by and get clothing on Sunday. And we would all sleep in the living room. For us, it was a big party, man. We get to snuggle up with our brothers and sisters. There was 8 of us total. And so I grew up with that way of life. And then as I decided to pursue, college, I went to college. I wanted to work in sports. I loved it. Played a lot of sports growing up. And so I went and decided I was going to be an athletic trainer. So I went over to the athletic training room and said, let's do this. And they put me to work 2 years, a lot of time, a lot of experience. And then I said, well, maybe I want to be a PT. So I did PTA for a little while. Eventually, somebody recognized in me some more ability, and they said, maybe medical school. And I made it over to medical school. So graduated, ended up taking the UW route, WAMI program, that takes all of us from the Northwest and eventually shoots us over to Seattle, and we get that wonderful training in that huge landmass of 5 Northwestern states, including Alaska. And then I got to residency, did family medicine here in Seattle, and started working. Once I started working, again, looking at all these situations, all these patients that we've got here, eventually realized that I had to get a fellowship in. And so I did that and came back, and I established this place to try and make an impact here. Ed, what was the question again?
Yeah, how
Oh, the FQHC. There you go. Okay.
Yeah,
So,
that's
yeah. So when I was in medical school, we got to do electives, and I went to a community health center nearby where my mom and dad lived. I just happened to be rotating in Idaho at that time. And it was like, where you been all my life, man? I saw my people there. I saw migrant workers. I saw people speaking in Spanish. I saw patient care in Spanish, and I was hooked. So when I got back to Seattle, I decided I wanted to establish, primary care, family medicine as my chosen residency. I did my 3rd-year clerkship in Seattle at a place called CMAR, right? So
right.
that was 2003. And then when I chose my residency, it's because CMAR actually had residents training there. And so I chose that same residency with that clinic and then took a job with them, never looked back. And
Wonderful.
I just think it's such a good model of care. Federally qualified, like I said, great quality. Everybody comes to the door. Nobody gets turned away. And, you know, you can have some crazy ideas and they may look at you kind of funny, but they will consider everything. And what I learned here is that if you try hard, you work hard, you gain the trust of the patients, you do good care, you kind of build that loyalty, index. And pretty soon they start leaning on you from an administrative standpoint. They give you more leadership opportunities. And then I had this idea. I said, why don't we send me to fellowship and train me, and then I'll come back and I'll put this clinic together. And they're like, yes, let's do it. So that kind of ability, that kind of arena to practice in, where you get an idea and they're not only going to say yes, they're going to put money toward it and they're going to invest in it. And that's where this came from. And
Right.
I don't know if that's a unique story, but I mean, it worked out, and it's
Yeah,
been a
it's
whole lot of fun.
no, we love it. It's your story, and it's obviously something that you're passionate about and are doing a great job in. So, uh, applause. I'm going to hop over to the chat, Dr. Perez. A couple questions in there. One of the questions that we're seeing is, when you were building out your practice, was there any pushback for specific things that you wanted? Needed that, or things that you needed, like equipment, or if there was pushback on the price of the equipment because of the
Sure.
specific funding.
Yeah, absolutely. So there was a little pushback, and then other times they were saying, no, you need to shoot higher. For example, when I was in fellowship, I found a grant. I got $380,000 from this benevolent billionaire. Now, I don't know how I stepped in that, but it was good. And I recommended an X-ray machine. I recommended an ultrasound machine, and I was willing to go with a used X-ray or a lower tier X-ray. My CEO said, "Nope, we're going to go for the top of the line." I said, "So explain to me how you make that decision." He says, "Because we can deduct on the depreciation of hardware." So what I found is that they will give you the best hardware that you can find, no problem. Happy to do it. But if I'm looking for wrist braces, boots, things like this, $8 wrist brace versus a $10 wrist brace, they're going to go for the $8 wrist brace
Sure.
because we can bill for a wrist brace, but we don't get that much money for it. And so they look at those losses over dozens of clinics, and the risk is that we're going to lose a lot of money every year. And so what I essentially came to is I said, okay, we have the primary care gear and we have the sports medicine gear. Okay.
Yeah.
And the sports medicine gear, I will not bend on. This is what we need. In primary care, I make sure that this is good enough, but this has got to be great. And so they were okay with that. And since we only have 1, 2, 3, 4 practices right now, it's not a lot of money lost. In addition to that, what I can tell them on an economic model, on a business model, you come to see me for 30 minutes, I can diagnose you with a consult. I can get an ultrasound and I can do a procedure all in one 30-minute visit. And I can document because I'm really fast. I'm good at what I do now. I couldn't do that when I started, but I'm good now. I can do that. And if I lose $10 or $20 on a boot, who cares? Because I
Right.
just built $1,000.
For sure. For sure. I'm sure dictation helps too. If you're using some sort of oral dictation.
All dot phrase, man.
Oh man.
All dot phrase, epic and dot phrase.
I
But we
love it.
have
I
we
love
have
it.
Dragon, so people who want to dictate, absolutely. We try and give
Yeah.
our providers anything they need to make them fast and efficient.
Very good. Very good. What another question from the chat. What incentives are you able to offer to retain sports medicine physicians in the FQHC setting? It's a noble cause, but obviously a lot of people
Yeah,
think about the financial
sure.
side, and that's increasingly becoming more important to a lot of physicians coming out. So
Yeah.
just curious about that and a question in the chat.
Yeah. So I had a partner one time was going around looking for a job, and she had one piece of advice from our CMO. He said, "Please look at the entire package. If you just look at the dollars, no one's ever going to pick us. Look at the entire package and look at the value of that." And so, good advice. So she went and talked to a lawyer. She got a bunch of contracts. She laid them all on the ground, and then lawyer said, "Yeah, if you take a look at the total value of this thing, this contract right here, that's the best. So what do you get for that? You get your salary." Um, our salaries have an annual cost of living increase. And that can be anywhere from, we've had zero in the past when we were having trouble during the economic recession of 2007, which is when I went to fellowship because we had to. And then we made it up later because why do we do that? We chose to do that so our staff would get paid and not get laid off. Okay, we did that as doctors. But we went through the pandemic just now. We got 6% increases every year because cost of living is rising and inflation is bad, right? Just barely starting to cool off now, but we've had a couple of bad years of inflation. I know that people need cash. I know it's expensive to buy a house. I know that people have loans to pay. Okay. So what we do is we take that cost of living every year, and then you have what's called a base salary. That base salary goes up every year. Okay.
Yep.
On top of the base salary, if you have a residency training, that's $2,000. If you have fellowship training in sports medicine, $10,000. Every year you get a certain amount of, I think it's 8% added from the total salary that goes into your retirement. And so all of these things
Sure.
grow logarithmically the longer you stay.
Got
Okay. If
it.
you stay for 3 years, the velocity of your salary goes up pretty quickly. Before, we would take that velocity and chill it out a little bit on the 6 years, and then it was fairly stable after 6 years. And so we knew that 6 years we had to do something, right? What was that something? Traditionally, we give our doctors sabbaticals. Anybody get sabbaticals anymore? Right? It's a thing of the past, but not here. Every 3 years, you get 3 months off. All your um, uh, insurance and all your benefits are intact. If you wait 6 years, you get all that plus half your salary. Okay.
Oh,
So
okay.
that is tremendous for us. Every 3 years, I know I can take off and disappear. I don't have to do nothing. And everything's going to be intact. I'm going to be fine. Okay. We get
Yeah.
very generous PTO. We get very generous CME. And it comes with decent dollars that expand out after that 3 year mark. We want people to stay at least 3 years. That's the idea. But our contracts are yearly, honestly. You sign a contract, it's year at a time. Okay. We
Absolutely.
want doctors to not feel roped in and hogtied. We want to make sure people feel open, that they're here because they want to be here, that they
Yeah.
have support, right? And that they have freedom to move if they need to or want to.
Yeah,
Okay.
that's of an utmost importance. It
Yeah.
really is.
Yeah.
In terms of the contracts also, just another question about that. is that something that's independently managed by each FQHC, or is that
Mhm.
more of a federally negotiated contract?
Good question. So no, I looked this up. There's no template contract online from HRSA. I talked to my CMO and I said, "Where'd you get our contract?" He said, I don't know. We lifted it from another FCHC years ago, 60 years ago when we started, and we have just massaged it and modified it with the time based on what our providers want and what, the times call for.
Got it.
But by and large, it's a base salary with incentives. And then, every year when you're, getting, your salary renewed, there's opportunities for negotiation. And depending on how long you've been here and how much value you bring to the organization, gives you that leverage to negotiate. And I have negotiated several times. I'm the one that got that 10,000 bonus for sportsmed docs because I think we bring so much value to our patients, and the CMO had to agree with me.
Very good. 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 Another question from the chat, Dr. Perez. Out of curiosity, how do you best provide consistent PTOT for the working folk who can't afford or can't attend PTOT on a consistent basis?
Right. Yeah, great question. So when I came here, I always wanted to bring PT in-house. We finally found a mid-career, very dedicated physical therapist to join us. She worked with us for 3 years. Then she took a break, went down to California, tried a faculty position that she liked, but wasn't exactly right for her, and came back and decided she wanted to work with us again. But she wanted to be the clinical director, and that's what I was hoping for. I needed somebody to be captain of the ship. And what we realized after analyzing our finances during that time is that patients come in, and you have to realize we take care of people from 50, give or take, countries, different backgrounds, different languages. And they're not coming into us with physical therapy as a known therapeutic. They're not
Right.
coming to us with preventive care even as a known idea. They go to the doctor
Right.
when they're dying, when they're bleeding, when they're infected. And so it's a huge shift in their approach to to taking care of themselves. So what we realized is that we were able to get maybe 2 visits for a patient before they disappeared. And after talking with our billing department, it's because they got the bill and then they disappeared, right? And they never came back. So we had to add more value to that first visit. We made it, instead of 30 minutes, every first visit, it's an hour. Every first visit gets
Nice. Sure.
hands-on. Hands-on is the main way we take care of our patients. There's manual therapy, stretching, massage, fenestration needle, acupressure, whatever it takes to give them great relief, great hands-on care, because people feel that care better when there's hands on the body.
Yeah.
That brings them back for the second visit. We get more opportunity to do that education, and then more and more we're starting to see people as we educate the community, not just word of mouth, not just doctor to patient. I get on the radio and we talk about this frequently, okay? In
Yeah.
Spanish to our main population, which is our Spanish-speaking population, about physical therapy, what it is and why it's good for you. And so now we're starting to get people sticking around for 6 and 12 visits.
Yeah. That's great. That's great.
Yeah. And
Um,
again, sliding scale, they can pay less for good care.
exactly.
Yeah.
Exactly. And so you're meeting them exactly where they are,
Yeah.
which is
Exactly.
extremely important.
Yeah.
How do you think that we moving forward can expand this idea of FQHCs into residencies and fellowships?
Right. So a federally qualified health center, most of us who have been in training would agree that is a great place to train because again, people come to you with amazing pathology, right? Uh, what I see today, I see a lady who's pregnant. She's got insulin-dependent diabetes. She's got a BMI of 40, and we're doing STs, AFIs, and she's going to get induced at 38 weeks. Right? That's just kind of bread and butter. That's a complicated patient for primary care, but great for training, right?
Yeah.
Great for training.
Yeah.
We get folks that come in. I had a lady come and she had crossed over the border, jumped off the fence, broke both ankles, pylon fractures, both ankles, operated on in Texas, transferred to New York, operated on there, came to me. That is
Yeah.
just every day you see people coming in that have been through it. So definitely a good place to train. And then at that point, most federally qualified health centers do not have their own residency programs. They don't have their own fellowships. We've been doing this a long time. The
Yeah.
program I trained in was a collaboration with Providence that then switched over to become Swedish Cherry Hill. So we have 2 residents at one of our clinics as a continuity clinic. But all the administration, all the dollars come and go from Providence as an organization. What
Yeah.
we did eventually was started our own family medicine residency in a different region, different county, because there was a shortage. It was a service shortage area, which is our job. We're there to take care of access to care. So the state of Washington asked us, would you guys please consider doing a residency and training doctors? that was the dream of our chief medical officer. He really wanted to do this. So we did it, and we had about 6 years running. And eventually I got a little bit tired of watching folks come and go. And I said, look, we got to start training our own sports med docs because this
Yeah,
is a huge need. And we need to find people that have heart and want to stick around and want to do this job.
absolutely.
So we're in the process now of doing that. We're getting partners, and
Right.
it has to be, if you want it to be affiliated, or what do you call it, accredited, fully accredited ACGME, it needs to be connected to a family medicine residency.
Right.
So we want to do that internally. We've explored unaccredited and the differences. You know, there's things that are easier, less boxes to check, right?
Yep.
But there's definitely, you eat what you kill. So we
That's
have to be able to pay those fellow salaries if we don't have federal dollars coming in.
for
So
sure.
it's still a little bit in negotiation, but by next month, I think we ought to have the answer.
Sounds good. That sounds good. Well, great answer to that. Kind of segueing off of what you just spoke about too, and the breadth of things that you're seeing at the FQHC. I'm curious, what is your particular, because you spoke about the pylon fractures, you spoke about 30 weeks gestation in a pregnant patient that also had other complications. What's your overall split, Dr. Perez,
Yeah.
in terms of family medicine, sports medicine? And then part two to that question would be, do you have any negotiation room to change that split?
Oh yeah, yeah. So tons, actually. Again, I'm here to take care of the patients. Whatever they need is what I do. So I flex my schedule. My ideal schedule would be maybe a day or two of primary care, 2 days sports medicine, 1 day admin, maybe a half day off so I can make sure I go teach a dance club for my little girl at
Right.
school.
Yeah, that's right.
Yeah, yeah, very important. You take care of your kids,
That's
right?
it. That's right. That's right.
So let's say during the pandemic, I had a shift way over to the hospital. Man, tons of call, tons of outpatient work, not much sports med work, but I had a full-time partner with me. He was managing almost all that. Then he took a job elsewhere, and I had to shift back over here and do the majority of the sports med coverage. So I get 2 half days a week in primary care. All right, still get a half day of admin. And I'm able to, again, do enough curbsides and enough co-management that I can still keep my next available reasonable. And I have great staff that help me find patients for no-shows and cancellations. So I mean, we're doing okay, but we can definitely do a lot better. And that's the whole reason we want to start training people on site, see if they want to
Yeah,
join us, see if we want to take a job.
it's great. Yeah, the flexibility, that's great. And it's good to hear that too, right? So
But you know,
very good.
when we're talking to the CEO, it's all about the patient, and that's important. It's all about
Always.
the patient. Whatever the patients
Always.
need, you know, we go there. We go there. We build the systems, we build the services. It's all about the patient. Once it becomes about me, then I don't get a lot of support from leadership, and I totally get that.
Yep. Another question in the chat, Dr. Perez. What's a strategy to leverage your ask to the admin's bottom dollar? And who would you present this to in the FQHC organization's leadership structure?
Right. So I think talks like this, learning about how people can be creative and still bringing in income and still and taking care of patients. Always look to the mission. You know, federally
Yep.
qualified health centers, the mission is access to care. If you always look to that mission, your leadership should at least hear you out. But you're going to have to come with good ideas. Yeah, so I think absolutely center the mission and center the patient, and make sure that your idea, you've researched it well. Talk to, hopefully, the FQHC that you're considering has a chief medical officer, a CEO, a chief financial officer. Those are 3 important people to chat with. A chief financial officer, talk to that person in your organization, in the organization that you're approaching, and see how they get paid. Very
Absolutely.
important. And
That's
then,
great
and
advice.
then remember that what we do, I mean, think about it. I went to a sports medicine fellowship. That's an American Board of Family Medicine, fellowship, right? Yeah, this is primary care. And so it's not hard to say, guys, I want to keep doing primary care, but we have all these patients that get musculoskeletal issues. I'm going to go to
Yep.
fellowship. I'm going to come back and do it again in a bigger scope. All I'm asking from you, and this is what I did with my people, 7 years out, I got a salary here, guys. I'm not going to take a fellow salary. I got bills to pay. You
Yeah.
have to
Yeah.
backfill that for me.
That's,
You
yep.
backfill that for me. When I come back, now I'm up to here. I negotiated my contract because I got
Yeah.
skills now. Okay. And then I owe them 3 years. That was the deal.
Right.
So
Right.
I happily gave them 3 years. If I left, 2 years, 364 days early, I'd pay the whole thing back, right?
Yeah. Yeah.
That's no problem. I said, bring it on. I'm going to do
That's right.
this. This is what we need to do. So that was
Love
just
that,
one
man.
idea I had. But you need to come to people with a win-win-win, right? That was a win for the patients, is a win for me, win for the leadership, win for the
Yeah.
organization. You got to
Yep.
come for win-win-win.
That's exactly right. And that's true in any negotiation, right?
Yes.
So
You gotta
that's
find a way for
absolutely
everyone to win.
that's absolutely right. That's absolutely right. A lot of excitement about this topic, Dr. Perez, and being the face now for the sports medicine in the FQHC, you may end up with more questions than we have. Is this
I have an
something that,
email and I check it every day.
yeah, and I was going to ask, is this something that you'd be willing to share your email, maybe in the chat
Yeah,
for the participants, if there's
sure.
questions,
Yeah.
that we could, they can even ask you further. That'd be great. I'll open this up also. Are there any other questions in the chat? This has been an excellent presentation and discussion here by Dr. Perez. A very exciting topic. Is there anything else that we can address here tonight for you guys? Give it a second, and it doesn't seem like there's anything going on in the chat. So that's great. Again, Dr. Perez, this has been fantastic. Thank you for your time. Thank you for the education on what you do and how more people can get involved in this as well.
All right. I appreciate this, guys. It was an
Uh,
honor to share this with my colleagues. And I just want to say that I'm here anytime you have questions. I'll do whatever I can to support those ideas. And I look forward to seeing presentations from other people in different parts of the country now talking about their practices and FQHCs and all the wonderful service that they're doing and all the fun they're having. Thank you so much.
Absolutely. Thank you guys. One more quick plug for our next webinar as well, which again is going to be on December 4th. So check the emails for that, and we look forward to seeing you all there. All of this is also recorded, and you can watch this anytime you want on the AMSSM YouTube channel. All right, everyone. You guys have a great night.